Hello, good afternoon. My name is Susanna, and I will be representing groups 7, 8, and 9B. We are honored to present to you the last, but definitely not the least, CPC case. So this is a case of a 23-year-old male, single Filipino Roman Catholic, born in Tondo, Manila, and currently residing in Dasmariñas, Cavite, who was admitted for the first time at De La Salle University Medical Center with a chief complaint of behavioral changes. The history of present illness started 2 years prior to admission when the patient experienced recurrent left flank pain with tolerable intensity and was described to occur about once a month. It was associated with fever, which resolved spontaneously. There were no dysuria noted and no medical consultation was done. 2 months prior to admission, he experienced difficulty in micturition associated with urgency, fever, chills, and hypogastric pain. He sought consult at a hospital and was prescribed with sulfamethoxazole trimethoprim that afforded him relief. A month prior to admission, he was admitted at the same hospital for oliguria. He then underwent peritoneal dialysis and was again subjected to peritoneal dialysis, which elevated his condition. He was prescribed magnesium and was sent home. 9 days prior to admission, a lymph mass with a draining sinus of purulent material was noted. It was associated with body anorexia, weight loss, fever, and chills. 7 days to admission became oliguric, which persisted until 4 days prior to admission. He presented with vomiting, anorexia, and generalized body weakness. 12 hours prior to admission, he was noted to be restless, talkative, disoriented, and later assaultive and combative. This prompted the family to seek medical consult at DLS UMC, where he was subsequently admitted. For the patient's past medical history, he had an incompletely treated primary complex at age 4 and a history of recurrent UTI since he was 6 years old. He has a positive family history of pulmonary tuberculosis involving both parents. However, their treatment status was not disclosed. Personal and social history of the patient revealed that he is a heavy smoker, an occasional alcoholic beverage drinker, and works as a bus driver. Now let's go on to the physical examination results of the patient. And upon admission, he was conscious, incoherent, disoriented, restless, and in respiratory distress. Vital signs shows that he was hypotensive, tachycardic, tachypnic, and febrile with a temperature of 39 degrees C. Physical examination of his chest and lungs showed bronchi on both lung fields but no rales. PE of the heart is unremarkable, and upon examination of the abdomen, a firm left upper quadrant mass was palpated, 5 to 6 centimeter below the left subcostal margin, with tenderness elicited on his left hemiabdomen and left costovertebral angle. A draining sinus on the left inguinal area with yellowish mucoid, non-foul smelling purulent discharge was also noted. On physical examination of the extremities, grade 1 bilateral puting edema were observed, faint peripheral pulses, and cyanotic nail beds were also noted. Lastly, his neurologic exam showed that the patient was incoherent. On imaging, the patient's chest X-ray was unremarkable, and his plain-filled abdomen showed a density on the left hemiabdomen, displacing the inferior aspect of the transverse colon superiorly and the descending colon inferiorly. There were no abdominal calcification noted, and the osseous structures were intact. The patient's laboratory findings revealed leukocytopenia with slight toxic granulations on CPC, while results of his urinalysis showed pyuria, albuminuria, and possibly gross hematuria or hemoglobinuria based on the gross appearance of his urine. Gram stain and culture of his sinus exudate revealed the presence of Staph aureus. Likewise, culture of his urine, blood, and dialysate were also positive for the same organism. The next slides will show the result of the patient's blood chemistry to include his arterial blood gas analysis. His ABG revealed that he was in a state of metabolic acidosis from his first day of hospitalization until the day he expired. Results of the patient's blood chemistry further revealed that the patient had azotemia that persisted even after dialysis, along with his hyponatremia and hypochloremia that will be shown in the next slides. The patient also was hyperuricemic initially prior to dialysis. Nevertheless, we could see an improvement in the levels of his BUN and creatinine, which lowered after dialysis. In addition, results showed that the patient was initially hyperphosphatemic and hypocalcemic, which were relieved after 45th exchange of dialysis. However, hyponatremia and hypochloremia persisted. His potassium was within the normal range pre and post dialysis. During the patient's course in the wards, he was hypotensive despite normal central venous pressure, tachycardic with cold, clammy skin, and progressive peripheral cyanosis were noted. He was maintained intravenously on the following medications: norepinephrine, oxacillin, chloramphenicol, and tobramycin. The patient was stabilized over the next 24 hours but remained highly febrile. Peritoneal dialysis was continued, and he was then referred to the urology service, where continuance of dialysis and medical support were advised instead of surgical intervention. On his third hospital day, the patient was successfully resuscitated after an episode of cardiopulmonary arrest, but remained stuporous with fixed dilated pupils and negative caloric test. Despite being hooked to a mechanical ventilator thereafter, the patient deteriorated and passed away on the fourth hospital day. Now, for the salient features of this case, first we'll start with specific signs and symptoms, and these are recurrent left flank pains, dysuria, urgency, oliguria progressing to anuria, hematuria, proteinuria, pyuria, rhonchi on both lung fields, and density found on the left hemiabdomen as shown on his plain field abdominal X-ray. In addition are results of the patient's blood chemistry as follows, and the patient also presented with painful left inguinal mass with draining sinus with purulent discharge and positive blood urine dialysate and sinus culture of Staph aureus. Furthermore, the patient on history presented of fever with associated chills, vomiting, anorexia, and generalized body weakness. Upon admission, he presented with grade 1 bipedal edema and peripheral cyanosis as well as faint peripheral pulses. Also noted was behavioral changes in the patient. Notable risk factors for this case are the patient's gender, history of heavy smoking, exposure to TB during childhood, and a history of incomplete treatment of his primary complex when he was 4. We now proceed with our differential diagnosis. With the patient presenting with prominent behavioral changes with associated urologic symptoms, here is the list of differentials based on the most likely etiologies relevant to the patient's clinical history, physical examination, and diagnostic evaluation. These include vascular, infectious, neoplastic, congenital, genetic, and endocrine or metabolic. Our first differential is tuberculosis meningitis. We considered it because the patient has history of primary complex PTB exposure from his parents and presented with fever, chills, body malaise, weight loss, vomiting, anorexia, tachycardia, delirium, and behavioral changes, which are all characteristic of tuberculosis, especially when it affects the meninges. On the other hand, the absence of cough, cranial nerve signs or palsy, hemiparesis, headache, neck rigidity, seizures, hemi or paraplegia, and visual disturbances makes it unlikely to consider TB meningitis as this case is primary impression. Next, we have hypertensive encephalopathy. It was considered due to the following. The patient exhibited behavioral changes, disorientation, restlessness, logorrhea or talkativeness, and also presented with pyuria, oliguria, azotemia, and grade 1 bilateral pleating edema. We ruled out this disease due to the following. Patient was hypotensive in the wards, no hypokalemia, no episodes of seizure, absence of severe headache, no papilledema, no visual disturbances, and absence of twitching and myoclonus of the limbs. Renal cell carcinoma or RCC was considered because the patient is a smoker. He also exhibited behavioral changes which could be a manifestation of a later complication of this disease entity, such as brain metastasis or possibly uremic encephalopathy following renal failure. Also present in the patient is fever, weight loss, generalized body weakness, recurrent left flank pains, abdominal mass on the left upper quadrant, and bilateral pleating edema. It was ruled out because RCC is uncommon in people his age, and the peak age is usually 50 to 70 years old. The patient did not exhibit paraneoplastic syndrome, erythrocytosis, and hypercalcemia. Next, we have HIV-associated nephropathy. This may be considered due to the following points. The patient is a young adult, making him at increased risk of acquiring the disease if he is promiscuous. More so, he presented with behavioral changes, which is also a manifestation of its complication of uremic encephalopathy secondary to renal failure, fever, weight loss, and anorexia. Large kidneys on X-ray and bronchi on chest auscultation are also notable features. However, it may be ruled out because no sexual history predisposing the patient to HIV infection nor IV drug use were noted. In addition, HIV-associated nephropathy is a disease with insidious onset and hence can be ruled out as it contradicts the patient's acute manifestation. Autosomal dominant polycystic kidney disease, or ADPKD, was considered because it eventually leads to renal failure, predisposing the patient to uremic encephalopathy, causing behavioral changes accounting for the patient's chief complaint. Patient risk factors for ADPKD include his gender and age. In addition, we considered ADPKD because of generalized body weakness, recurrent left flank pains, hematuria, proteinuria, hypogastric pain, and a history of recurrent urinary tract infection since the age of 6. We ruled it out because of no family history, poor evidence of bilateral affectation of the patient's kidney, absence of nephrolithiasis, and abdominal distension and early satiety. Sepsis-induced acute kidney injury was also considered due to the risk factors present in the patient, such as history of recurrent UTI since the age of 6 and dialysis. Also, the patient experienced behavioral changes which, similar to the previous differential diagnosis, is a manifestation of its complication of uremic encephalopathy. It was also considered after the patient presented with fever, chills, recurrent left flank pains, dysuria, hematuria, proteinuria, oliguria, and bilateral pleating edema. However, we ruled it out due to the onset of manifestations of kidney insult, which exceeded 3 months, as well as absence of urinary sediments such as glandular casts or renal tubular epithelial cell casts. Next is chronic glomerulonephritis. This was considered because complications of which will also lead to renal failure, causing uremic encephalopathy, manifesting as behavioral changes. The patient also had pyuria, anuria, hypogastric pain, bilateral pitting edema, blood culture positive for Staph aureus, azotemia, and proteinuria. This was ruled out because there were no skin rashes seen in the patient, no polyarthralgias, long hemorrhage, recent skin infections, and because glomerulonephritis usually affects children aged 2 to 14 years old. After ruling out these differentials, we are left with these two diagnoses from infectious renal or genitourinary tuberculosis and from congenital anomalies of kidney and urinary tract. Vesicourethral reflux or VUR was ruled in because the patient manifested with recurrent UTIs since he was 6 years old. This could have predisposed the patient to have developed renal failure, thus manifesting behavioral change, along with fever, recurrent left flank pains, hypogastric pain, urgency, and oliguria. It may be ruled out because there were no resolution of symptoms with growth, no definitive diagnosis was made during his infancy and childhood, and no associated loss of control over bowel movements and burning sensation when urinating. Genitourinary tract tuberculosis was considered because the patient was noted to have the following risk factors. He is a young adult, a heavy smoker, and the PTB exposure from both parents were present in the history. He was noted to have behavioral changes which could have resulted from the complications of this disease, leading to renal failure and predisposing the patient to uremic encephalopathy. Patient also presented with recurrent fever, weight loss, generalized body weakness, recurrent left flank pains, dysuria, oliguria, has a left inguinal mass with a draining sinus, a bilateral pitting edema, and a history of primary complex at age 4 and recurrent UTI since the age of 6. It may be ruled out because the patient did not exhibit any urinary frequency, nocturia, or sterile pyuria. However, further diagnostic exams are necessary to completely rule out this disease. Our primary impression for this case is genitourinary tuberculosis, perinephric abscess, uremic encephalopathy secondary to chronic kidney disease stage 5. For the pathophysiology of this case, we start by recognizing the patient's history of primary complex at the age of 4 and the possible continuous TB exposure to both parents having PTB. Although he presents without any manifestations, his history stating his inability to take the complete course of anti-TB regimen may allow possible infections or inoculation with multi-drug resistant strains, and thereby putting him in an immunocompromised state. This may be considered as a latent TB case. Reinfection or reactivation through acquired cell-mediated immune response or aberrant immunity may bring an active TB infection over time. The latter may be supported by the patient's chronic exposure to cigarette smoking. It is known that smoking causes a chronic release in inflammatory mediators, causing narrowing of the airways, formation of fluid or cellular exudates, and mucus hypersecretion. In the event that these chronic damages in the respiratory tissues cause reactivation of a latent TB infection, the bacilli could spread hematogenously or via the lymphatics, causing genitourinary TB. Affectation of the kidneys would lead to formation of cortical granulomas and ureteral constrictions due to the formation of tuberculous nodules in the renal mucosa. This would cause obstruction in the collecting system, resulting in dilatation of the ureter and bladder wall thickening. Due to these chronic insults, it can be surmised that the patient may have had an obstructive kidney injury, which, when left undetected and untreated, may lead to recurrent UTI, which in this case was noted to start when he was 6 years old. Another factor that could have caused the recurrent UTI experience of the patient was the possibility of some congenital abnormalities of the kidneys and urinary tract, which cannot be totally ruled out due to the absence of diagnostic imaging modalities. These anomalies or abnormalities are considered to be the most common cause of recurrent UTI in early childhood. Due to the recurrent infections and inflammation of the urinary tract, recurrent nephron damage leading to irreversing scarring, fibrosis, tubular and glomerular loss were likely to occur. This may lead to the grave disruption of the kidney's normal physiologic functions. Failure of normal physiologic kidney functions will lead to the following: impaired sodium retention and water excretion, acid base imbalance, formation of active metabolites of vitamin D, phosphate excretion, erythropoietin production, and an increase in homocysteine, guanidine compounds, and cystatin C. Let us discuss them one by one. Increase in homocysteine, guanidine compounds, and cystatin C as byproducts of poor kidney filtration causes direct neuronal damage, which may lead to uremic encephalopathy. Early symptoms of uremic encephalopathy include vomiting, anorexia, generalized body weakness, and restlessness. As this disease progresses, patients typically become more disorientated, confused, and may exhibit bizarre behaviors, which are evident in the chief complaint of the patient. Impaired erythropoietin production is also an effect of kidney damage. As a result, the bone marrows make fewer blood cells, causing anemia, which in this patient manifests as body malaise, generalized body weakness, and progressive peripheral cyanosis. Loss of phosphorus homeostasis due to excretion failure in the kidney results in hyperphosphatemia. As we all know, phosphate and calcium in the body react in opposite ways. As phosphate builds up in the body, it will bind to calcium, which in turn lowers calcium levels. Thus, extra phosphorus can also cause hypocalcemia, which is evident in the patient's laboratory results before dialysis. Calcitrol, the activated form of vitamin D, is produced in the proximal tubule of the kidney, and this helps the body to effectively absorb calcium. With renal failure, there is loss of active metabolites of vitamin D, thus, there is an impaired intestinal absorption of calcium. On the other hand, parathyroid hormone normally stimulates the production of calcitriol. Hence, a decrease in calcium will stimulate the compensatory mechanism of PTH, which indirectly stimulates osteoclast activity to release more calcium in the blood. However, due to prolonged negative feedback, there will be skeletal resistance to the calcemic actions of PTH, which will eventually lead to hypocalcemia. Impaired acid-base balance due to impaired kidney functions, there would be decreased excretion of normally excreted uric acid in the urine, leading to uremic acidosis as observed in the result of the patient's arterial blood gas analysis. And uremic acidosis will then lead to resistance of bones to parathyroid hormone, leading to hypocalcemia. Impairment of sodium retention and water excretion will lead to disruption of electrolyte balance involving sodium and chloride. And we all know that the paths of secretion and reabsorption of chloride ions in the renal system follow the paths of sodium ions. Thus, hyponatremia will also lead to hypocholeremia. The decrease in sodium levels will stimulate the renin-angiotensin-aldosterone system to control the fluid and electrolyte balance, especially by excessive sodium retention, simultaneously causing expansion of the extracellular fluid volume. When this persists, edema ensues. In this case, the patient had grade 1 bipedal edema. Expansion of ECF volume will also lead to increase in preload and cardiac workload, as manifested by tachycardia. In some cases, the added strain may cause symptoms of congestive heart failure or concomitant affectation of the lungs, leading to pulmonary congestion, clinically manifesting as rhonchi and other abnormal breath sounds. All this will cause hemodynamic derangements in the kidney, which will eventually lead to medullary congestion and endothelial dysfunction. The downregulation of the production of nitric oxide, while upregulation of the production of endothelin will cause endothelial damage and renal autoregulation, such as tubuloglomerular feedback. Medullary congestion and tubuloglomerular feedback will lead to vasoconstriction. The downregulation of the production of nitric oxide, while upregulation of the production of endothelin, will cause endothelial damage and renal autoregulation, such as tubuloglomerular feedback. Medullary congestion and tubuloglomerular feedback will lead to vasoconstriction, causing an increase in renal venous pressure and medullary hypoxia, leading to ischemia. Back to endothelial dysfunction. Endothelial cells become activated and contribute to the pathogenesis of thrombosis, leading to activation of reactive oxygen species, then adhesion and migration of leukocyte will take place, triggering inflammatory response. Thus, this will also lead to an increase in renal venous pressure and a decrease in local blood flow to the proximal tubule, hence contributing also to ischemia. These series of events will lead to an injury to the renal tubular cells. Due to the failure of reabsorption by damaged tubular cells, protein wasting or tubular proteinuria is one of the consequences of this injury. Furthermore, a decline in glomerular filtration rate, which manifests as oliguria and eventually anuria, were also observed in the patient. Due to the aforementioned disruption of the normal physiologic renal function, the patient's condition progressed to stage 5 chronic kidney disease. Due to this condition, the patient were then required to undergo peritoneal dialysis. And because of this procedure, another site of infection opened and led to the inoculation of Staph aureus that spread hematogenously to cause further kidney infection. Since renal function was already impaired, the clearance of the said bacteria was also affected and thus formed necrotic tissue and pus. There were also pressure buildup that spread to the surrounding tissues, forming a perinephric abscess contained in the Gerota fascia. This was manifested as a tender mass found at the left upper quadrant of the patient, which upon imaging revealed densities. Also, this abscess most likely spread caudally due to gravity and evolved into a groin abscess observed in the patient. This was confirmed by the draining sinus from the painful left inguinal mass that revealed Staph aureus upon culture. The rupture of the abdominal mass may have also reached the psoas flank muscle, confirmed by the CVA tenderness experienced by the patient. The rupture and local extension was also responsible for the peritonitis that worsened the condition and caused septic shock, which explained the cold extremities, hypotension, tachypnea, and tachycardic by the patient. Patient subsequently deteriorated and eventually succumbed to death. So our clinical impression now is urogenital tuberculosis, perinephric abscess left, congenital abnormalities of the kidney and urinary tract. To consider primary vesicoureteral reflux, uremic encephalopathy secondary to chronic kidney disease stage 5, septicemia, pulmonary congestion secondary to renal failure, status post peritoneal dialysis. The final cause of death is, for the immediate cause, it's multi-organ failure secondary to septic shock. Antecedent cause, renal failure, septicemia secondary to perinephric abscess left. And the underlying cause is the urogenital tuberculosis to considered congenital abnormalities of the kidney and urinary tract and chronic kidney disease stage 5. That ends our presentation. Thank you very much for listening. God bless you all and stay safe.